Good afternoon, everyone. My name is Anna Meteliuk. I work for the Alliance for Public Health based in Kiev, Ukraine. But within this project, we work in terms of LADB, long-acting depot buprenorphine, in two countries, which are Kyrgyzstan and Egypt. And we are very lucky that we have already started our project in Kyrgyzstan, and I will be presenting some preliminary findings with you. So just to talk about Kyrgyzstan very briefly, it's a country in Central Asia. The population is about 7 million people, with about 25,000 people who inject drugs, which is about 3.5% of general population. And HCV prevalence reaches about 60% in certain regions. The OAT program has been available in the country since 2002, which is methadone. The most common OAT medication is methadone. Is available since 2002. In early 2025, they did represent buprenorphine, sublingual buprenorphine, and now within our project, we also presented the LADB, long-acting depot buprenorphine, as an OAT option. So what has been done so far? I was asked to talk about the feasibility. So what has been done so far to start the program overall? So first of all, LADB as an OAT option had been added to the National OAT Treatment Guidelines. This is a huge success. We were lucky enough that they were reviewing their protocols at the time when we were introducing LADB, and we actually got approved by the Ministry of Health. We also added LADB to the essential medicines list. This is also a huge step. They have this medicine list, which has about 26 points overall, and LADB is now one of them, which gave us the opportunity for uninterrupted procurement and supply of LADB for both private and public sector entities across the country in the future, which gives the country the opportunity to procure locally LADB if given that the funds are available and if it's on the market. We also introduced the detoxification program for LADB patients. Most of the patients were concerned, those switching from methadone to LADB, were concerned about those couple of days of withdrawal symptoms. So what we did is we introduced the free of charge detoxification program in private clinics for 2 days, for 48 hours, with medication included, so that they could stay there before the first injection of LADB. And we also worked on the people who inject drugs attitude toward LADB. What I mean here is that we heard a lot of concerns about people who inject drugs were anxious about LADB in general. So we actually brought a patient from Ukraine, the actual LADB patient, who presented her experience, and I will tell now more about that. So we called it the LADB advocacy tour. So we brought a 48-year-old female called Lena from Ukraine, who has experience with everything. So she was one of the first patients in Ukraine. She started with methadone, then she switched to buprenorphine, sublingual buprenorphine. Then she switched to Buvidal within the donation program. Now she's back to sublingual buprenorphine, waiting for the Unitaid donation to get to Buvidal again. So we visited 6 OAT sites across the country, which are selected for our project to be the Buvidal sites. We visited 2 NGOs, talked to active people who inject drugs to kind of promote Buvidal, right? So we had 2 meetings with CAB members, and we also had a huge meeting with stakeholders. So you can see pictures from that, and this is Lena in the middle, sharing her experience. So as of now, the LADB is already in the country. We have selected 3 sites which will be implementing, and they are already providing Buvidal LADB. As of Monday, 3 patients have already received their first injections. One patient is OAT naive, so straight from street drugs to Buvidal, and 2 patients have switched from methadone. And we have already collected the baseline qualitative data. We conducted 2 focus group discussions and 12 key informant interviews. And now I will share with you the results of the key informant interviews. So we conducted 12 interviews. Our key informants were the community representatives, the NGO lead, he's right here, the head of Republican Narcology Center, that's kind of the lead agency under the Ministry of Health responsible for the whole OAT program, the project PI, OAT providers, including both doctors and nurses, and the social workers. So the main domains we were exploring, they were the attitudes towards LADB in general, the potential barriers, concerns, the decision-making kind of process, main motivation to switch to Buvidal in our patients, the role of social worker, the role of psychosocial support, and advocacy. So now I will talk about all the domains in general. So the attitudes towards LADB is overall positive. I here provide some, some quotes, like for example, I really like this idea. I will not have to come to site every day. Maybe my wife will trust me more. Maybe I can earn more money and she will love me more. So, you know, why not, right? Well, that's obviously the community representative, right? So, the next one is curiosity. Like, for example, wait, why not try? Methadone was also something new one day. And only one person demonstrated some sort of mistrust. Like, is this another experiment on us? Are we the guinea pigs for them? And they all think that these are Americans doing experiments on them. But with bringing our patient, you know, and showing, she kind of, you know, so the interviews took place before, before our advocacy tour. So as for the potential barriers, our key informants, the respondents, they listed transfer from methadone, which is a huge, you know, barrier because of the change in medication. Like, for example, I'm concerned about my patients on methadone. They will be afraid to switch. What if it does not work for them? But of course, we have a huge mentoring program from our from our doctors from Ukraine who have experience with Buvidal already. So we have constant, like, bi-weekly calls and kind of try to spare those myths. So the next barrier is fear to start something new. You know, they've been on methadone for 20 plus years. I don't think they will be ready to start something new. However, for street users, this is a winner, I guess. Also, the withdrawal system, which is a little bit combined with the first one with transfer from methadone. So what should we do with those withdrawals? Won't they start using again? Some people mentioned no barriers. I personally don't see any barriers. Buvidal can be a real option for a lot of our patients or those who are still using and work abroad. In Kyrgyzstan, a lot of, not even people who inject drugs, a lot of people in general work in Russia, so they have to travel a lot, and Buvidal can be a real, like injections can be a real option for them because they cannot bring pills to many of the countries. So concerns, as for the concerns, the injections, this is interesting that our people who inject drugs are afraid of injections. So they say that, will the injection hurt? And there is a lot of concern if the injection will hurt. And for example, I'm only concerned about the injection. I hope that this is our mentor from Ukraine, will teach us how to do those. And they already taught how to do those. And also they are concerned about access to Buvidal in the future, because we only procure it for 24 months. So obviously everybody is concerned what's gonna happen next. For how long will it last? What to do after it is finished? But because we added it to the list of essential medicines and we added it to the national OAT guidelines, meaning we kind of provided sustainability of the program, so that given the price reduction and everything, the country will be able to procure it from the state budget. Okay, so the next one is decision-making and facilitating factors. So why would people start Buvidal? First of all, peer-to-peer, meaning that if somebody they know starts and has positive experience, of course, the people, the close environment will start as well. Like if someone they know start Buvidal and is happy, believe me, tomorrow I will have the line of potential patients. Then trust to OAT provider. When a patient trusts his doctor, he will do anything the doctor says. It is all about trust after all, and we do work with provider. We present Ukrainian experience and world experience and world evidence to make sure that OAT providers in Kyrgyzstan are kind of positive about Buvidal, right? Then OAT naive patients. Those who are on methadone could be cautious, but those from the streets, this is a real option for them. The next kind of facilitating factor is the confidentiality. I don't think the injection form of a month keeps patients away from our facility. This makes the program more confidential. I will count on them. So for some patients, we also conducted interviews with the patients who are saying that even somebody close, like wife, partner, or brother, sister, or mom, or dad who live with them, don't even know they're using drugs. That's why they cannot come to site every day, because they have to explain why they are away from home in early morning, for example. So for those patients, the injection would be a real option. And active social life. You know, those users, like, they're very busy, you know, they have stuff to do all the time. You know, those users, they do not have time for anything. This is a good idea for those with active social life, for those with no free time. As for the main motivation to switch to Buvidal, again, more free time, employment. Most of our patients cannot get employed because of the working hours of our site and employer. Buvidal can be an option for many. Again, confidentiality and ability to travel. This ability to travel mostly is connected with work, so they have to go to Russia to work, and this is an option for them where OAT is not allowed at all. So as for the role of social worker, everybody stated this is very important, especially from the beginning. They can't do anything without a social worker. It is crucial. No one starts OAT without a social worker. It's just impossible. And it's very connected with the role of social support, which is also very important. Believe me, my patients need psychosocial support even without Buvidal. It is very needed for adherence to OAT. I don't see OAT without psychosocial support, to be honest. And as for the advocacy, we're still working on it. Like I said, we did this advocacy tour, but it's also important to do advocacy among main stakeholders because this is brand new, so still not everybody is aware and not very, I can't say positive, but not very inclined, you know, to start Buvidal. So everybody expressed the opinion that there is not enough information overall. Like, since this is a new drug and a new form of drug, the users are afraid. They need a lot of information to build trust. And of course, need for evidence. One patient told me that if he had talked to someone who injected it, I would believe. As of now, this looks like a fairy tale. Maybe it will become a fairy tale after all. They actually do not think this is real. They need more evidence. That's pretty much it for my presentation, for my results. I would like to thank the Unit Aid team, the Frontline Aid team, the Partnership Network team, who all are here from our Kyrgyz colleagues, Alliance for Public Health team, and especially Alla Besonova from Kyrgyzstan community member who helped me with all the analysis. Thank you.